So we have Dr. M. Vijayakumar, sir. He's the Vice Chancellor of Yenepoya University. So good evening, sir. Welcome to 5th CanCom. It's a pleasure to have you with us. And sir, you're one of the pioneers of surgical oncology in India, and one of the first, I can say, the MCH oncologist. And in your almost vast experience, how can you say that the landscape of cancer has changed over these years?
Good evening, and thanks for inviting me to be here. It's a good conference going on with the ISO MVR CanCon. I had come to say this, I am completing 40 years by this December in cancer surgery alone. Out of which around 31 years I spent in Kidwai Cancer Institute, which is a premier institute at Karnataka and one of the well-known regional cancer centers, now upgraded to State Cancer Institute. And currently I'm working in Yenepoya University, where we have started Yenepoya Institute of Oncology, supported by Tata Trust. And we have programs like MCH Surgical Oncology, DM Oncopathology, MD Radiotherapy, BSc Radiation Technology, and BSc Nuclear Medicine Technology, apart from having programs like all complex surgeries go on, reconstruction, rehabilitation surgery go on, including microvascular surgery, and robotic surgery is added for the last 8 years. Coming to the medical side of it, we are not only treating adult tumors but also pediatric, and we have also added last 5 years bone marrow transplant. The most important thing is we are doing all this for most of the time. 98% of the time, the patients are belonging to below poverty line. That means the patients are poor and needy, and they reach us, and this sort of high-end treatment is given to them free of cost through the government schemes many times. Why I started saying that is, in the last 40 years, the most important thing, if at all, has happened is the financial support from the government. Whatever technology and technical expertise we develop, we get, and we improve upon and upgrade ourselves. To make it reach to the poor and needy, what is important is the willingness to do that free of cost, and it has to be supported by some funding agency or the other. In the last few years, in the state government of Karnataka, it was there for about 10 years, now 12 years. Now we have amalgamated with the central government scheme, what is called as Ayushman Bharat Arogya Karnataka. This important one I am telling in the beginning only in the finance part of it, because irrespective of what we do, what we learn, to make it reach the public at large, society at large, and reach the poorest of the poor, then somebody has to fund. And I'm very thankful to the Government of India and the state governments to come forward for this assurance scheme. This is the most important thing I would say in the beginning itself. Otherwise, though we had the expertise 40 years ago of contemporary expertise, I would say what other countries were having, we were having, but we are not able to reach the public mainly because of this. And secondly, the certain complex surgeries were not available at that time. They have to learn and come, and only few people and few centers were doing. Today, most of the centers across the country are doing. And thirdly, the availability of drugs. So we must make one available, two accessible, three affordable. All three are now made available today in our country. Most of the centers who are treating cancer are comprehensive in nature, and they are making it available to the public at large. And these drugs were not available at all during my early days in 80s up to 90. It was not available. And so only after the opening up the global, all these drugs which are now made available outside are already available with us. And the third most important thing with respect to the drugs is our country has started producing a lot of biosimilars so that the cost of treatment is drastically brought down. This I am repeatedly telling few things is one is importantly the government policies to make it available, accessible, and affordable. And these three things are important before we, as specialists in the field of cancer, work with the people and give them the best.
So you have started a great initiative in your university, a cancer awareness outreach program for reaching the even the grassroots levels. That's a great initiative, sir. Can you just share a few?
Good you asked me, because many of the cancer specialists, including cancer surgeons, are so good in their skills and competency, but to make it useful for the public, the patients have to reach in time. The most important, by reaching in time, what I mean is they have to come in early stages. The 2020 or 2018, the ICMR white paper, if you see, not even 12% of the patients who are reaching the cancer centers are doing so in the early stages. That means 88% of them are coming in so late stages, either stage 3, stage 4, making all our efforts, both technical and financial, a waste. So, to make things better, we have to catch them early. So, there are three types of prevention, as you know. One is primary prevention, another is secondary prevention, and the third is tertiary prevention. The primary prevention is about creating an awareness and health education so that you teach them what is right and what is wrong, to do's and not to do's. So that is what we can all do at every level and any level. And that is what I started doing when I reached that university, using the NSS programs, National Saving Scheme programs, under the Department of Youth and Sports Activities. That is where I started. And I started using the NSS platform very well, I would say, using the neighboring universities also. We started about 10 years ago. When I reached there, I saw the organized way it is functioning, and so I used them, both our universities, NSS, and also the NSS of the neighboring university, that is Mangalore University. Under that Mangalore University, there are three districts will come. That is Dakshin Kannada, Udupi district, and Kodagu. All these three districts were covered by us, and about 13,000 NSS volunteers were trained along with their mentors, 135 program officers and coordinators. What we did was very simple. That is, we created IC materials, and then we went and spoke to them about this, and then we created the digitally available material, which is written languages in the local language, that's Kannada, and in English, but dubbed in at least 7 languages. The voiceover is given in English, Kannada, Malayalam, Bari, Hindi, Konkani, and Tulu, so that the local population and the neighboring districts can be covered, so that the people who are carrying that need not struggle with their language. This is what we did. Seeing what we are doing, quite a few people came for our help. One was the Rotary Club of Mangalore, and Rotary International came and said, we will try to partner with you. What do you want? Then I asked for a specialized bus, which is around 1.5 crores worth it, wherein it is a self-sustainable bus which has got facilities like mammogram and colposcopy, etc., with which we can go to any rural place. And I said self-sustaining because it has got its own generator, and even with the places where there is no electricity, we could run it and do that program to all the rural people. Once I started doing this, rural people, the community oncology people, community medicine people joined with us, and we started training the Udupi district Asha and Anganwadi workers, 2,000 people. We trained them. We went to the next step. We not only gave them the knowledge of the cancer awareness, but we also told them how to do early detection. This takes us to the secondary prevention. So the early detection program was done, and in the early detection program, we taught them how to do cervical smear, PAPS testing, and how to teach them the breast clinical examination and the self breast examination and oral cavity. This is what we did. Seeing what we did, we are also wondering In fact, I was wondering, we are all doing all this, what is the impact? So the impact analysis we wanted to do. When we try to do impact analysis, that's a big money. And Tata Trust Mumbai came forward to sponsor that whole program, and we could come out with 1.5 lakh people covered to know the impact of what we did in these three districts and the district of Udupi. So therein we found out that the reach was only around 15 to 20%. And so we started getting people from all over India and asked them how to go forward and do these things. They gave some inputs. Based on that, we modified and we are doing it. Seeing our work, again, NSS Department of Youth, Empowerment and Sports, Government of Karnataka came forward and asked us to do the same thing across the country, across the state of Karnataka. But it was a 4 lakh population volunteers. So I said it will not be good. Every time we can't be training 4 lakh. So we modified it and we started training the program officers and program coordinators. So 4,000 program officers and coordinators were trained, so that in turn they will go and train the volunteers, subsequent volunteers who will come year after year. So 4,000 people were trained in and across 40 universities in the state of Karnataka. Again, partially sponsored by Government of Karnataka. And then after doing all this, they said, why don't you take it to the from rural population, why don't you go to the tribal population? So we are working with 5 districts in Karnataka with it on tribal population and doing not only cancer awareness, but early detection of NCD, that is non-communicable diseases, including cancers of the oral cavity, not ovary, oral cavity, breast and cervical cancers. Along with that, we are trying to detect early detection of anemia, hypertension, and diabetic mellitus. This is what we are doing for the last 3 years with government at 5 districts in Karnataka state. This is what we are doing, and we are continuing to do our program.
So it's a very good, great initiative, I could say. So I think if it covers all of India, it will be a huge venture, but we will be able to even reach the grassroots levels, early detection, and it's a very commendable efforts from your part.
The last bit what I forgot to tell you was that seeing all of us working, the ICMR asked for a implementation research program. They called for an expression of interest. 184 people are from all over the country applied for it, and we are one among the 6 selected by them, and we are the only one medical college hospital selected for this program, which is the Cancer Early Detection Implementation Research, funded by ICMR. We just got the clearance and we got the funding part of the first year funding has reached us. It is a 3 years program wherein we'll have to work with the district administration of Dakshina Kannada district, that's Mangalore district. Along with that, we have to work with the NHM, that's National Health Mission of Government of Karnataka, that we have just initiated.
Okay. So wishing you very best for all the future ventures, sir. So in short, sir, could you give us a short advice how should be the next line in cancer management go, increasing the technology, the awareness. I think you have covered all this awareness part, but technology, should it go hand in hand, in especially in urban population,
As I said in the beginning of my talk, the technology, yes, we have to go upgrade ourselves. As I said, we have last 9 years, we are doing a robotic program, minimally invasive program, microvascular reconstructive program, complex surgeries go on like IPEC, etc. That is true. And also, if you look at the radiotherapy part of it, you have got SBRT, SRSRT, brachytherapy, and we are having other supportive things like PET CT, MRI, 3 Tesla MRI, CT, and more importantly, what I would say is the bone marrow transplant and other chemotherapy aspects. But all these come with a cost. So that is where in the beginning only I said, who will bear the cost is one thing which we should always bear in mind when we are upgrading the technology. I am not against technology. In fact, I am trained in both reconstructive surgery as well as robotic surgery. But to reach the masses, I think we have to keep in mind the cost of the treatment, and always we have to try to reduce the cost. For one of the things which I have done back in our university is to develop a Yenepoya technology incubator, wherein we are able to produce our own 3D printed uh, patient-specific prosthetics. We call it implants. For it may be for mandible, it may be for chest wall, it may be for long bones. Thereby, it's nothing new to get a patient-specific implant because I myself am using it for last 25 years. But when you do it all this in our own setting, the cost will be around 10 to 15% of what we are now getting from outside the country.
Okay. Thank you, sir. And can you just give us some for CanCon of 5th edition? So, any message?
The message for all youngsters is you will have to update yourselves and upgrade, no doubt, and otherwise you will be rejected. On the other hand, expecting somebody else to do the job for you is not right. When you want to eat the food, you have to earn the food. So when you have to operate on your patients, you want to treat the patients, you have to earn the patients by your good work and going and outreaching the places in the community, thereby developing their confidence and trust in you. Then only that will happen. Thank you.
Thank you, sir.